Well, good afternoon, everyone, and thank you for allowing me to join with you remotely today as I talk about strengthening pre-hospital emergency medical services in rural and remote areas in Mongolia. My name is Duncan McConnell. I am a senior lecturer at the School of Medicine and Dentistry at Griffith University. So just before we get started, quick little disclaimer. As I've mentioned before, I work at Griffith University as a senior lecturer in the School of Medicine and Dentistry, and I've been actively engaged with Mongolian and international agencies throughout my research in Mongolia since 2018. Now, some Mongolian government agencies discussed in this presentation, Griffith University has active memorandums of understanding with. However, my connection with them is via the established Griffith University MOU and not as their representative. So let's get started. So you will find that I've got a few QR codes scattered throughout this presentation. That one takes you to my contact details. So feel free to scan it and that'll bring up an electronic contact business card for you. So I'm not there physically to hand any out. So who am I? My name is Duncan McConnell. I'm a senior lecturer at Griffith University in the School of Medicine and Dentistry, particularly focusing on paramedicine and pre-hospital emergency care. I work as a paramedic practitioner, an academic and a researcher, and have over 29 years of clinical experience across Australia and international service delivery. As you can tell by my fancy little outfit there, I'm a qualified pilot. I'm full-time at Griffith University. I work part-time as a clinician. I'm also the president of the Australian Institute of Paramedic Practitioners here in Australia. And internationally, I'm a board director with the International College of Advanced Paramedic Practice that focuses on aeromedical, community paramedicine, and critical care-based transport. So how did we get here? How did I end up working in Mongolia? And how did I start working with the Mongolian Society of Emergency Medicine in helping them identify ways in which they can improve not only their pre-hospital emergency care response within the capital, but in the key rural and remote areas as well. So since 2008, Griffith University has been actively engaged in training and development with the Mongolian Ministry of Health via our Australian Department of Foreign Affairs and Trade. And DFAT is how I got involved in this in the first place. So where I have been completing my doctoral thesis, the Centre for Environment and Population Health, along with DFAT, have been providing some significant training and board opportunities for Mongolian health officials across health, public health, and emergency care. What DFAT was actually doing was providing both short courses and bringing whole families over to Australia so they could complete master's degree programs in public health, for example. In 2018, I was working on another project in the Maldives, and Griffith International approached me and asked if I would be interested in doing something similar in Mongolia. And that is how I ended up in the wonderful country that is Mongolia. The Mongolian Society of Emergency Medicine have supported this research tremendously, as has Seth, my PhD thesis research centre. And without that support, the findings of this research and today's topic certainly would not have been possible. So without further ado, let's get underway on today's topic. So one thing I wanted to touch on today, and this relates really strongly to Australia, is a term called the tyranny of distance. Now, those of you who live and work in Mongolia, you would know that it is a long way to anywhere when traveling rural and remotely, especially if you need to get back to the capital, Ulaanbaatar. So Mongolia does have an area size of 1.5 million square kilometres and a population of 3 million. But what's interesting about your population is that 1.5 million of them live in that capital there. Now, all those other big red dots represent provincial capitals, and there's a few cities or towns that are dotted there as well across this map as well. So this plays significant interest into enabling high quality pre-hospital emergency care in rural and remote areas, because there is a long time for help to get to where the bulk of your primary tertiary services actually are, which is Ulaanbaatar. So let's just touch on that a little bit further. So within UB, all your tertiary hospitals are located, managing your complex medical and surgical care and trauma. All the private hospitals are located there, as well as other things that tourists often have access to, including SOS Medica. All agency headquarters are located there. So that includes your Ministry of Health, NEMA, the military, and the police. The main airports for Mongolia are located there. And it's where all major medical emergencies are transported to that can't be managed in the AirMag general hospitals. So let's have a look at your more remote areas across Mongolia. So all AirMag general hospitals are located here, and they do handle the diagnostic and medical and paediatric type and basic trauma and surgical opportunities that may present. Some hospitals are more that sort of lower level, basic outpatient care. The rural and remote ambulances often run out of there, and they do have some small inpatients and emergency wards as well. Now, all major medical emergencies that can't be treated at this level do need to be transported back to UB. And that then presents probably one of the biggest hurdles for your rural and remote emergency medical practice. By road, time and distance can often take a very long time to go a very short distance. And some of the roads can be quite bumpy, which can be quite challenging for certain patient types or condition types. And then you've got air. Now, certainly a lot quicker. However, time plus distance equals a lot of money. So air retrieval is not cheap. So that inherently imposes another problem as well, making it very challenging in those rural and remote locations. Other key challenges sit around human resources, equipment, and distance. Now, if we look at human resources, having senior experienced clinical staff in those rural and remote areas can be quite challenging. Often there's only one or two. There's generally quite a few junior clinical staff. However, speaking with people across Mongolia in the last two regional visits that I had, they are now finding it harder to get junior staff going out back to those rural and remote areas once they've completed their medical training in UB. And by having limited senior clinical staff, enabling ongoing professional development in these areas and training becomes challenging as well, because sometimes the senior staff don't have time to do the upskilling or training they need so they can help develop those junior staff as well. And then we have our ambulance drivers and ambulance driver development. That's really crucial, and we're going to touch on that a little bit later in today's presentation in areas of improvement and possible development opportunities that could really improve service delivery in your rural and remote locations. And then equipment. Often in these rural and remote locations, low resource, low equipment. So it does make it very challenging for clinical response capabilities. And again, training is often limited in that the seniors may not have time to do it or may not be qualified to do it, and relying heavily on either expats like myself or people that have completed training in UB to come out and deliver training remotely. And then you've got the old distance. Nothing is going to beat the distance. It's hours by road and sometimes hours by air, and often really long wait times. And that's also critical in some of the things we're going to talk about shortly. Now, the reason I wanted to touch on human resourcing is that by 2030, and newsflash, that's only 4 years away, it's 2026 now, the WHO predicts a shortfall of 18 million health workers across low to middle income countries, especially doctors. Now, Mongolia fits in that, they're more in the middle income area, but that's quite frightening that within 4 years, there's going to be a significant shortage. So how do we turn a potential threat towards healthcare delivered in countries like Mongolia into opportunities and potentially strengths? So we all operate within a traditional healthcare approach box. Everyone's got their ways of doing things, ways that are done in North America, Europe, Australia, and across Asia. Mongolia is a little bit more different in that sense, in that you inherited a post-Soviet medical system. And since your independence, you have been working towards modernising and transforming that. And by all accounts, from what I've seen, especially since 2018, you've come along leaps and bounds and you're doing an unbelievable job. Now, if we take our traditional healthcare approach box and we try to apply that in a low resourced rural and remote location, we're going to struggle. And sometimes we need to think outside that box. And really, today's presentation is how do we think outside that traditional healthcare approach box and make it work for us? So, how do we leverage off these opportunities and turn them into strengths, particularly in these rural and remote locations? So, I feel the best way to do this is via a multidisciplinary approach. And there are many different, and these multidisciplinary areas don't necessarily need to be health related. Everyone working together as one is what really transforms success in rural and remote locations when it comes to patient care and particularly delivery of healthcare. Healthcare is bigger than your traditional healthcare approaches. So, what about ambulance drivers? What roles do they play moving forward? So, ambulance drivers, we're going to touch on a little bit later, and it's a little project that the Society and I have been working on for a number of years now. Moving on, NEMA. People look at NEMA and think, well, there's firefighters and rescue workers. Well, we're going to touch on that a little bit later as well, because work that we've done over this past 8 years has really started to identify some key areas of development, particularly within those two locations. What about the police? Yes, they're there to help police and look after things, but how can they help in this space as well? Prison workers. Well, people might think, well, that's an odd thing to put up in this little circular diagram that I've created. But often prisons are located in particularly remote and sometimes rural locations. And they're often all alone for long periods of time. Tourist guides. This one I've been looking at for a number of years now and had the opportunity, thanks to Dr. A, in meeting with a whole bunch of them in a particular location. And I feel tourist guides are certainly a missed opportunity that could really provide some substantial better approaches to your pre-hospital response. And by getting this right, will increase tourists wanting to come to Mongolia as well and have a bit more of a tourism approach to funding the country as well. So that's a really, we'll touch on that one shortly too. And health promotion. You can't not talk about stepping outside the box without speaking about health promotion. Now, the Ministry of Health is doing some wonderful things in that at the moment, but there's ways in which you can leverage that even further when you're working in these rural and remote locations. So let's talk about expanding capabilities and what we currently have. And I'm focused more so in this presentation about rural and remote. So let's think about rural and remote healthcare delivery. How can we improve it? Well, based on some of the findings that I've had recently, and looking at some of the 5 key areas that the Ministry of Health is looking at in improving healthcare delivery, particularly in the rural and remote locations, I've come up with what's called an essential service triad of support. And what that is 3 key areas, all of which are currently in a rural and remote location spread across Mongolia. That's an opportunity. And it's an opportunity you can turn into a strength. Hence, my essential services triad of support. So let's start to break down this triad and why it would benefit rural and remote communities. So, ambulance drivers, they're more than a driver. They really are. They can provide so much more if we provide the right opportunities and expansion in a well-governed and approachable manner that helps existing capabilities. So what if we could provide a certified training program taught at a train-the-trainer level which I'll touch on later as well, that could help improve the capabilities of our ambulance drivers. Now, by no means am I trying to turn ambulance drivers into doctors. What I'm trying to do is a doctor is one person. They have one pair of hands. And when the going gets tough, that one pair of hands could use a help. So what if that one pair of hands could be two pairs of hands? Foundational, fundamental skills that could be utilised to assist the doctor in really critical situations. So instead of them being on their own, now they've got a helper. So some of the things that we've come up with for that is obviously history, pre-hospital emergency care, that type of stuff, just giving them a bit of an overview of where things have come from and where they are now and where they fit in, and that they're a key part of this process. They're not just an ambulance driver. They're a key part of rural and remote ambulance response. And go through things such as basic patient assessment, patient history, more basic patient assessment techniques, basic pre-hospital toxicology and environmental conditions, basic trauma care and management, manual handling of patients and equipment, and managing multi-casualty incidents. Now, by incorporating a course structure such as this into the development of ambulance drivers, it provides an opportunity that can be turned into a strength to help improve your capabilities in rural and remote response. Now, this course could be delivered intensively. We've worked it out. It could be done over about a week, week and a half, or it could be delivered in bite-sized chunks over a period of one night a week. Because you also need to take into account the limitations people have of being able to do this while running a live operational emergency service. So by structuring a course in such a way that can be delivered both part-time or intensively, it enables us to be able to roll this out in a structured way. Now, before we move on, what about NEMA? What about them, you might say? Well, NEMA is a very, very interesting opportunity in a rural and remote location. They are strategically positioned all across the country. And if positioned next to a major hospital, sometimes if the ambulance is busy on another case, NEMA might arrive first. They might arrive first to that major trauma before the ambulance arrives with the doctor and the ambulance driver. What if we could provide the same level of training that we provide ambulance drivers to NEMA? What if we were able to incorporate that into their current induction training for all new employees and then turn this into a professional development course that's taught out in the remote locations? Now, again, we're not trying to turn NEMA firefighters or rescue workers into ambulance drivers, doctors, or anything like that. What we're trying to do is sometimes if they're first on scene, some of these basic assessments can make the difference between life and death for our patients. So by providing training in this sense, we're able to provide some of that initial basic stabilisation and training that previously they wouldn't get until the ambulance arrives. Furthermore, now you've got an ambulance that arrives with two pairs of hands to assist the doctor. You now also have a NEMA crew with an additional set of hands that might be able to assist as well. So particularly when we talk about managing multi-casualty incidents, by having more people trained in basic approaches to how we could improve our response, that provides an extra bit of assistance for a doctor that would have previously been overwhelmed. Therefore, increasing and expanding current capabilities. Now let's move on to the police. Now they are a slightly different approach, but sometimes the police do get to car accidents and other things before NEMA and before the ambulance. So what about expanding their knowledge in advanced first aid? Really focusing on fundamentals and being very job specific. BLS skills. And again, not trying to turn them into NEMA rescue workers or ambulance drivers, but just trying to give them some foundational skills that could make that difference if they're there before the ambulance, or NEMA. Stop the bleed, hemorrhage control courses. Focus on quick control of catastrophic hemorrhage control, penetrating injuries, keeping patients warm. Things that can make a difference is if there is a delay in those other essential services turning up. And working within multi-casualty incidents, focusing on collaboration with other services and initial first-person response. What if they are the first vehicle or emergency service that turns up at a bus rollover or two cars that have got a total of 10 patients in them? Providing them with those basic fundamental skills that could make a really big difference with that initial response in these rural and remote areas. Remember, we're low-resourced, low numbers of human resources. So we need to look at ways of expanding these capabilities moving forward. Hence, your essential services triad of support. Having all these systems working together can greatly improve and increase current capabilities and improve healthcare delivery in these locations. So let's move on to a couple of those other areas that I discussed. So prison workers, working within the Mongolian prison system or corrections. Now, fairly similar to the police approach in that we would look at advanced first aid, focus on fundamentals and be job specific. And the reason I really want to be job specific here is because what might work outside of prison may not work within a prison. And that's where tailoring some of these courses really makes a difference. BLS skills, stopping the bleed, hemorrhage control. That's a really bad day when that's happening in a prison, but it does happen. And focusing on the things they need to do to really stabilise that patient prior to definitive care arriving. Multi-casualty incidents can occur within prisons as well, so working out the best ways to approach those and contextualising that within prison. And then that sort of produces a prison guard that's more than just a guard now. It's a prison guard that can provide some of that initial support, some of those initial services, helping other medical staff who may be there while they stabilise the patient or patients until an ambulance or ambulances arrive to transport them on. Now, what about tourist guides? Tourism is a potential gold mine for Mongolia. And one thing about tourism is it's often in the really remote, really hard to reach places of Mongolia, because let's face it, it's absolutely beautiful, and that's why people go there. People want that horseback riding experience. People want that camel excursion experience out over the Gobi and watching the sunrise and sunset. I mean, it's amazing. So what about training our tourist guides up to provide some key fundamentals to help provide that initial response and care prior to definitive care arriving and taking over? And I think we could step more towards improving some areas of basic patient assessment, patient history gathering, some more advanced patient assessment techniques, basic pre-hospital and toxicology management, which could be seen out there. Basic trauma care and management is big, falling off horses, camels, falls, all that type of stuff, broken bones, quite common. Manual handling of patients and equipment. They might need to make a makeshift stretcher or something like that to support their patients until help arrives. Multi-casualties, they can occur on these trips as well. And I think probably the most important part about this is prolonged field care management. Often tourist guides are on their own for a long period of time, a long way from anywhere. Hopefully ambulances can get there. Otherwise, it may be air. But either way, it's prolonged. Normally with your expat and tourists that have their travel insurance, SOS Medica normally fly out and retrieve. But again, that takes time. Helicopters don't just start up and take off and are there in 10 or 15 minutes. It can be up to 2 to 3 hours. Now, what about our health promotion? How else can we expand current capabilities via health promotion? And I think this is the missing gold mine in small communities in these rural and remote areas to really build a healthy population and really understand what they have and what they need. So I think community first aid training is a big, big plus in getting that established in your rural and remote locations. And focusing on things like what to do when I see it, how to do it, how I apply what I see. Who do I call? What's my action moving forward? School-based first aid training. Get in early. Primary school, high school levels. Not only does this provide a large group of people that we can train up in first aid skills at an early stage, what a great way to introduce our future healthcare leaders and next generation of health practitioners. That might light that spark in primary school or high school or both. And they want to become that next health professional in Mongolia. Maybe they want to come back and continue to work within their own rural and remote location and bring advanced skills back. But what an opportunity that's too good to miss. And the final area there I think is vital with your health promotion in rural and remote locations is health literacy education. People don't know what they don't know. So by being able to produce health literacy education to inform them of what they need to know in key areas can help them understand when they need help and what they need to do to get help. A classic example is herdsmen and their families, and I know this is a key priority within the Ministry of Health at the moment. Now, one thing I remember significantly when doing some herdsmen working with their families in clinical assessments and things like that was speaking with a gentleman who had diabetes. Now, it was diagnosed, he was given some medication to help treat and manage it. And then when he was seen a little bit later, all the symptoms had started to come back again after they'd gone away. Why? Because the herdsman didn't understand that he needed this medication for life. And that forms part of health literacy. Again, people don't know what they don't know. So it's working through things like that so we can keep them healthy, we can keep them where they need to be, and we can keep them in these traditional settings longer. And that's what health literacy is all about. And if we're looking at expanding our capabilities in rural and remote locations, getting that small prize done right makes a big difference for the future. And that builds local communities, everyone understanding and working together. And that helps establish these areas. Now, I haven't spoken about doctors yet. So let's focus a little bit now on expanding capabilities for ambulance and rural doctors. And this is something the Mongolian Society of Emergency Medicine and I have been very passionate about from the start. So how do we make this work as we evolve overall pre-hospital emergency response across Mongolia? I think a key area that really needs to be taken into account in these locations is prolonged field care in the emergency setting, really ensuring that our ambulance and rural doctors have a sound, thorough understanding of approaches, techniques, and ways of applying this will greatly increase your capabilities in your rural and remote response. And then moving through contextualizing what pre-hospital emergency care patient assessment looks like outside of a clinic, outside of a hospital, outside of what you've learnt in a university setting. Working outside those environments is completely uncontrolled. I've been doing it for 29 years. No day is ever the same. And then providing advanced airway approaches in the low resource setting. Pre-hospital toxicology and environmental conditions, identifying them outside the hospital and key techniques and tips for doing that. Incorporating PHTLS, which has been going since 2019 now, which is awesome to see, and now has a series of trainers, Mongolian-based trainers, to be able to deliver this. And I was fortunate enough to be part of one of those training courses last year when I was in country. Point of care ultrasound, again, another great initiative that's been introduced across this space that needs to be incorporated into ambulance and rural doctors training. Managing obstetric emergencies in the pre-hospital environment. Again, totally different to managing it in a hospital. You're it. Hence why it is important to be able to incorporate this as key learning opportunities to expand the capabilities of these doctors. And then manual handling of patients and equipment and how to use it correctly. And working closely with the ambulance drivers so you're working as one, not as two individuals. And managing multi-casualty incidents, which occur a lot, particularly in your high tourist season, um, and knowing how to do this and working collaboratively with the other services to be really successful in doing this. Now, again, this type of program has been developed in such a way that it can incorporate in stuff that's already been done, such as PHCLS and POCUS. It can be delivered in an intensive approach, and it also can be delivered in a staggered approach over multiple weekends or individual nights as well. But what's really important about all of these areas, about all of these clinical trainings, is it needs to be practical in its approach. We can't just sit in a classroom, look at a whiteboard, listen to someone talking. We need to be practical in its approach so that we can apply it in the most appropriate way. And that includes doing it in the snow. And this was a program I was running in 2023. It was in November, and I think it was about negative 32 that day. It got to negative 38 a few times, but really contextualizing our approach, really contextualizing what we're needing to do. Now, this training here was very much focused on ambulance doctor training, so it was more advanced. However, just because it was focused on ambulance doctor training, it doesn't mean you can't contextualize it backwards to focus on ambulance drivers or focus on potentially training police, NEMA, prison workers as well. Again, contextualizing that practical approach is what is the linchpin and the key for enhancing your abilities in these spaces. Now, talking about your ambulance drivers, talking about NEMA and talking about prison workers or police, they haven't gone through and done intense medical university training or education like our doctors have. So establishing quick reference guides such as this, and this is an example from earlier work that we did, that gives prompts to people that don't do this regularly or are new to it, that aids them in their clinical approach, it aids them in their patient care so that they're able to actually ease their way into it and not feel nervous. Because whenever you do something new or for the first time, you always wonder, oh, how am I going to remember this? Okay, so providing tools, so establishing tools. And again, these would be incorporated and encouraged to use throughout this training and development. This then moves into other examples. This was multi-casualty management. So this was a slide that I utilized explaining how the framework works when we're assessing our patients very quickly in that first 10 to 15 seconds. As you can see, we have the Mongolian on one side and the English, for my benefit, on the other. And this is a universal system that's used internationally around the world today. Now, there are many different MCI frameworks you can follow, but this was one that we chose as it was the most simplest at the time of doing this. So again, incorporating that. And then what we did was we ran scenarios where we put people in cars and buses and other things like that. And we got them to go around and practice using this so it became second nature. And we had NEMA personnel doing it. We had police doing it. We had doctors doing it. We had ambulance drivers doing it. Really showing everyone working as one in that collaborative approach. And that brings me back to agency collaboration. Now, this is an actual medical incident in Dakar that I was part of in 2018. And as you can see, we had everyone there. We had doctors. We had NEMA. We had the police. Everyone was involved and everyone was working in a quite synergistic way making this work. And this comes back to my earlier statement of establishing an essential service triad of support. Ambulance drivers, NEMA, police, all working with the doctor to produce that healthcare delivery model. Now, what about professional development and remote learning? What do we need to do to maintain skills? How can we reach out from a distance and help do some ongoing continuing training and professional development? Well, learning gateways are a great way of doing this. Now, this is an example of the work I was doing in the Maldives that put me in Mongolia. Now, I know they're in two completely different locations and two very completely different weather systems. But this is just to give you an example of how we maintained and continued professional development, which they're still doing today, using a learning management system like this. Now, this will never replace face-to-face practical training. However, it can be utilized in such a way that you can preload your participants before you turn up. So let's say we're doing a very remote training session. It's going to take a day and a half to get there by car, and we want to provide some preloading to our participants before we arrive. Well, we can put them up in the LMS. They can watch the videos, take notes, and then instead of wasting half a day of training looking at PowerPoints and going through them step by step, they've already watched them. So we can then spend maybe 20 minutes going over the key points, and then another 10 minutes, so 30 minutes in total, another 10 minutes asking any questions they might have, and then we can get into the important stuff, which is the practical application of the skills we're there to do. So this is a tremendous way of reaching people from a distance. And then there's the equipment donations for training and response. Now, a key thing that's come out of all the work I've done over the years here is that the reason sometimes training doesn't get done to the level that it needs to be done is because they don't have any equipment that they can utilize for training, because what they do have, they need for response. So donations for training have played a big part. And one thing that has been pointed out to me is how difficult it is to actually buy some of this equipment in country or have it imported. So it's an area that needs further investigation. However, whenever we can and whenever I can, I will always try and bring as much equipment over as I can and leave it there so that it can be utilized for either training or increase operational support capacity. One of the things we did do in 2023 when we did a big observational study on feasibility of doing a train the trainer program for developing ambulance drivers with ambulance doctors was we bought over a whole heap of equipment for training. Now, at the end of that session, that didn't come back to Australia with me. That got divided up amongst all the participants so they could then take that training equipment, because it couldn't be used operationally anymore, but they could then take that training equipment back to their locations. So now they had something they could use for training. Now they could replicate what they've done with the equipment moving forward. But I think future-proofing to sustainable development, I think the key for future-proofing is train the trainer. Create a future-ready workforce. Everyone in that picture was part of a train the trainer program of me back in 2018. So here we were doing advanced assessment techniques, which they were then able to then take back and train other people where they work. Train the trainer is vital. And if COVID-19 has taught us anything, it is that we can be locked out at any second and you can now be on your own. So what if people like myself or other trainers can't get in to train new skills or to continue training that we've done? You'll train the trainers are able, they're there, they can stay and they can develop the next generation, and then they become train the trainers to develop the next generation after them. So future-proofing and growing your rural and remote response in Mongolia, train the trainer is key to that. And all of those things that I've discussed earlier throughout this presentation are designed to be train the trainer courses so that you can continue to develop where you're located. And what about application? How do we actually implement this? How do we implement this change? Well, a big aspect of my overall research thesis has come to developing a framework of transformational change that can be implemented within a live operational healthcare system. Now, one key aspect of this is it's not designed to take a whole bunch of things and do it all at once. It's designed to take your key identifiable needs and then move them into a spot where you identify what you have, that systems that are already in place, and what systems you then need to develop. Sometimes you might need to develop a few, sometimes you might need to develop only one. And then the real linchpin of this whole transformational framework of change is identifying the educational approach that's needed to make the new systems successful. If you don't have that designed and developed, hence you train the trainers, then it's not going to be successful and it's not going to be implemented. So once you've implemented the educational application of identifiable needs, you've done the training of your staff, it's then operationalized, it's then implemented, and you run it. You reflect on it. You look at how it goes. You see if it's meeting the governance. You see if it's meeting your implementation of identifiable needs. And you determine whether it's success or whether it needs modification. And that circle can work across all aspects of change and implementation you would want to actually implement across a rural and remote location. So what about collaborative research approach? Well, most importantly, I have to say none of this work would have been possible without the Ministry of Health, the World Health Organization, Mongolian team, and the Mongolian Society of Emergency Medicine. None of this work would have been possible without them. And collaborative research is how you evolve. Collaborative research is how you take evidence best practice from other areas and look at it and identify how or if you can implement that within your own system. And all of the evidence-based research from 2018 to 2025 has produced some very interesting key themes. These themes include education, specialisation, legislative support, and operational infrastructure. And I'll talk about those more in a minute. But from the work that has been done recently, it has been compiled into this publication, which you can access by scanning that QR code. So before we discuss the key themes and close out today's presentation, I'll just leave that there for a moment so you can scan that QR code. So let's just touch briefly on research findings before we finish up, and I join you live via the Q&A. So education, key themes throughout that was clinical training is key. There's an absolute ravenous appetite for clinical training and contextualizing it for your needs. National centres, like let's set benchmarks for national centres for pre-hospital emergency care and make it like a specialty. Okay, we'll touch on that in a sec. University training for key areas for ambulance drivers and potentially maybe paramedics in the future, and agency development to incorporate the education that is needed. And then specializations. Look, currently introducing a new medical specialty like paramedicine would be a little bit of a mistake purely because the infrastructures and structures are not there yet. However, you still need the specialization training for your doctors that are running on your ambulances. So why don't you make it a specialty, just like you've made emergency medicine a specialty, and have that trained through the universities as well? And then maybe that would make it more appealing for people to work on ambulances and work in rural and remote locations if it was a specialty. And then we've got aeromedical. Now, this one's more of a niche specialty, and at the moment, primarily located within NEMA in their aeromedical area. But again, an aeromedical specialist is a key certification to ensure people responding in that capability are able to perform the skills at an international level. And then we need legislative change. We need legislation to support all of these changes and developments across your public health law and law on medical and services. And then overall operational infrastructure to make this come together. So vehicles, ground, air, clinical equipment, response locations, and future-proofing to ensure you're able to build and continue to grow in this space. Now, some of this is very, very big picture, but many of these areas are very vital to a successful development in rural and remote locations as well. So thank you very much for your time. I'm sorry I couldn't be there in person, but by the magic of technology, I'm now going to join you live for a quick Q&A. Again, QR code down the bottom there takes you straight through to my virtual business card, and I'd be happy to chat to anyone after this conference with any further questions you might have as well. Thank you again for having me, and I look forward to joining everyone on the Q&A. Bye for now.